Good morning, everyone. My name is Andrea Paula Favi Inosente, and we are the Group 2. And for this video, we are going to report the interventions of emergency conditions, which is the medical emergency and the disability. For the medical emergency, the airway, breathing, and circulation. For foreign body obstruction, inhalation injury, anaphylaxis, thoracic emergency trauma, cardiac arrest, and external hemorrhage. For the disability, the head injury, and the stroke. The reporters will be Wendell Galacame, Crystal Babes Hongko, Princess Ferhana Sarigan, Donna Fuentes, Jotham Enyano, Kiara Donaire, Ace Labadan, Aisa Hamza, and Jezreel Hayes Gadia.
My name is Wendell T. Hilikami, and I am going to discuss about the airway, breathing, and circulation. So, airway. Initial survey of the airway focuses on ensuring airway patency. Patency can be rapidly evaluated by asking the patient to say his or her name. If the patient is able to verbalize, immediately airway management is unlikely necessary. In patients who do not respond to questioning, the gag reflex may be checked using a tongue blade or more preferably the suction catheter. The lack of a strong gag reflex implies inadequate airway protective mechanisms and a patient in full respiratory arrest or with inadequate airway protection requires immediate intervention. In traumatic or unconscious or obtunded patient, the airway is most often compromised by the tongue, which tends to fall posteriorly against the soft palate. Adjustment of mandible using the head tilt chin lift or jaw thrust maneuver is often sufficient to open the airway. Simple adjuncts such as the nasopharyngeal airway or the oropharyngeal airway can greatly improve airway patency. The next one is breathing. Most cardiopulmonary arrest victims will not breathe spontaneously. Adequacy of respirations is determined by observation of the chest for symmetric rise and fall and by auscultation of the chest for bilateral air movement. In patients with absent or inadequate respirations, delivery of two positive pressure ventilations by bag mask device or mouth-to-mouth with a protective barrier is indicated after the first round of 30 chest compressions has been completed. So, successful bag mask ventilation confirms airway patency and may stimulate spontaneous breathing. If there is no pulse and no breathing, give 5 cycles of CPR to the patient, and the ratio is about 30 is to 2 for about 2 minutes. So, assess pulse and breathing pre and post 5 cycles. So, if patient has pulse and no breathing, the patient will have gasping in breathing, labored breathing, and abnormal breathing. So, for adult, give 1 rescue breath, and ventilation is 5 to 6 seconds. For child or children, give 1 rescue breath for 3 to 5 seconds, and for infant, give 1 rescue breath for 3 seconds of ventilation. And if the patient has pulse and breathing, position the patient into recovery position. And lastly is circulation. Chest compressions are the rhythmic application of pressure over the lower sternum, intended to create blood flow by increasing intrathoracic pressure and directly compressing the heart. To correctly perform chest compressions in an infant less than 1 year of age, press down 1.5 inches with 30 compressions at a rate of 100 to 120 beats per minute. To correctly compress the chest of the children or the child about 1 to 8 years old, press down 2 inches with 30 compressions at a rate of 100 to 120 beats per minute. And for adults, for about 8 years and older, press down 2 inches with 30 compressions at a rate of 100 to 120 beats per minute. Circulation assessment begins with a checking for central pulses at either the carotid or femoral arteries. A provider should spend no more than 10 seconds determining the presence or absence of pulses to avoid delays in initiating CPR. In the absence of a definite pulse, CPR is initiated. So stop CPR if the patient has spontaneous breathing and circulation. Turn over to trained personnel. Operator is exhausted. Physician assumes responsibility. For example, declares patient is dead. And lastly, scene is not safe anymore.
Good morning everyone, I am Crystal Babes J. Hongko and I will be going to report the foreign body airway obstruction or what we called FBOW. For the table of contents, first is the description, second is the pathophysiology, third is the signs and symptoms, and fourth is the nursing management. Now let's talk about what is FBOW. It is described as a clinical emergency that may be life-threatening. Besides complete foreign airway obstruction that is immediately life-threatening, partial airway obstruction can impede gas exchange and lead to dyspnea, pneumonia, and abscess formation. For the pathophysiology, airway obstruction can occur in anywhere from the larynx to the bronchi. Spasms and edema results from airway obstruction and become more severe. Obstruction in the larynx above the vocal cords has a better prognosis as therapeutic maneuvers tend to be more effective than when obstruction occurs below the larynx, which may necessitate removal by instrumentation. Also, the degree of obstruction is important as a partial obstruction will still allow passage of air and may provide additional time before the patient becomes hypoxic. Simultaneously, the patient's effort to expel the object decreases over time, making spontaneous expulsion of large object less likely. While impossible to control, the amount of air trapped in the lungs at the time of complete obstruction will affect the pressure produced by therapeutic measures such as abdominal thrust to remove the object. Stridor, a variably high-pitched respiratory sound, is a common physical exam finding in airway obstruction. The cause is attributed to rapid turbulent flow through a narrow airway opening. The reduction of airflow increases the energy expended to remove air across the airway, resulting in turbulent airflow and subsequently stridor and respiratory distress. Stridor is typically heard on inspiration but can also be audible on expiration in severe obstruction. This biphasic stridor suggests severe fixed airway obstruction at the level of the glottis, subglottis, or upper trachea. For a third phase, signs and symptoms, sudden onset of respiratory distress, coughing, wheezing, and stridor are the common signs and symptoms of a person with FBOW or foreign body airway obstruction. Gagging warrants emergent action and should elicit a high suspicion of FBOW. The choking patient may show the universal sign for an airway obstruction by grabbing his or her neck with both hands. When the patient is stable, the clinician can obtain their history. Particular attention should focus on age, either very young or elderly, intellectual or neuromuscular disability, and precipitating events such as eating or playing with toys. For the nursing managements, the approach to choking patients should begin with an assessment of ABCs: airway, breathing, and circulation. The clinician should focus on skin color, level of consciousness, and work of breathing, noting chest wall retractions, nasal flaring, and the use of accessory muscles. The physical exam features include stridor and hoarseness for laryngotracheal foreign bodies, and unilateral wheezing and decreased breath sounds for foreign body in the bronchi. A pharyngeal examination is necessary, and if there is a visible foreign body, it may be removed, but avoid blind finger sweeps. The pharyngeal exam should also evaluate for other causes of stridor and respiratory distress, such as epiglottis and pertonsillar abscess. Another nursing management is to assess the severity. For mild obstruction, the patient is able to breathe, cough effectively, and speak. Children are fully responsive, crying or verbally respond to questions, may have a loud cough, and be able to take a breath before coughing. Severe obstruction may indicate victim being unable to breathe or speak or vocalize, wheezy breath sounds, attempts at coughing that are quiet or silent, cyanosis and diminishing conscious level, particularly present in children, and the victim being unconscious. In nursing management for adults, in mild obstruction, encourage the patient to continue coughing. However, do nothing else except monitor for deterioration. In severe obstruction and unconscious patient, stand to the side and slightly behind the victim. Support the chest with one hand and lean the victim well forwards so that the obstructing object comes out of the mouth rather than going further down the airway. Second, give up to 5 sharp back blows between the shoulder blades with the heel of your other hand, checking after each if the obstruction has been relieved. If unsuccessful, give up to 5 abdominal thrusts. Stand behind the victim who is leaning forward. Put both arms around the upper abdomen and clench one fist. Grasp it with other hand and pull sharply inwards and upwards. Continue alternating 5 back blows and 5 abdominal thrusts until successful or the patient become an unconscious patient. Lower the patient to the floor. Call an ambulance immediately. Begin cardiopulmonary resuscitation or the CPR, even if a pulse is present in the unconscious choking victim. For the children, if coughing immediately, just encourage the child to cough and monitor continuously. If coughing is or becoming ineffective, shout for help and assess the child's conscious level. If the child is conscious, give up 5 back blows followed by 5 chest thrusts to infants or 5 abdominal thrusts to children. Repeat the sequence until the obstruction is relieved or the patient become unconscious. For infants under 1 year old, back blows and chest thrusts. In a seated position, support the infant in a head downwards, prone position to let gravity aid removal of the foreign body. Support the head by placing the thumb of one hand at the angle of the lower jaw and 1 or 2 fingers from the same hand at the same point on the other side of the jaw. Do not compress the soft tissues under the jaw, as this will aggravate the airway obstruction. Deliver up to 5 sharp blows with the heel of your hand to the middle of the back between the shoulder blades. After each blow, assess to see if the foreign body has been dislodged, and if not, repeat the maneuver up to 5 times. After 5 unsuccessful back blows, use chest thrust. Turn the infant into a head downward supine position by placing your free arm along the infant's back and encircling the occiput with your hand. Support the infant down your arm, which is placed down or across your thigh. Identify the landmark of chest compression. This is the lower sternum, about a finger's breadth above the siphisternum. Deliver 5 chest thrusts. These are similar to chest compressions for CPR, but sharper in nature and delivered at a slower rate. For children 1 year old to puberty, back blows and abdominal thrusts. Blows to the back are more effective if the child is positioned head down. A small child can be placed across the lap, as with an infant. If this is not possible, support the child in a forward-leaning position. Deliver up to 5 sharp back blows with the heel of the one hand in the middle of the back between shoulder blades. After 5 unsuccessful back blows, abdominal thrusts may be used in children over 1 year old. Stand or kneel behind the child, placing arms around torso. Place a clenched fist between the umbilicus and siphisternum, ensuring no pressure is applied to either landmark. Grasp this hand with your other hand and pull sharply inwards and upwards, repeating up to 5 times. If the child becomes unconscious, place him or her on a flat, firm surface, shouting for help if none has arrived. Open the mouth and look for any obvious object. If one is seen, make an attempt to remove it with a single finger sweep. Do not blind finger sweeps. If unsuccessful, begin CPR as for pediatric basic life support. Begin with 5 rescue breaths, checking for rise and fall of the chest. Each time, reposition the head each time if a breath does not make the chest rise before making the next attempt. For the complications of the foreign body airway obstruction, if not treated, inhaled foreign body, after successful treatment for choking, foreign material may be still present in the upper or lower airways and cause complications, such as bronchiectasis, bronchiectasis, or lung abscess later. Anyone with a persistent cough, difficulty swallowing, or with the sensation of an object being still stuck in the throat should therefore be referred to A&E. The X-ray may show an opacity that requires removal at bronchoscopy or atelectasis. In children, clinical features and radiological findings may have a poor correlation with findings at bronchoscopy. If a foreign body is suspected, bronchoscopy should be performed at an early stage for best result. Iatrogenic abdominal thrust can cause serious injuries such as gastric and splenic rupture. All victims receiving abdominal thrust require examination of the abdomen with a particular view to visceral injuries. And lastly, hypoxic brain injury and death.
Good day, ma'am. Good day, classmates. Today, I will be reporting about the emergency nursing interventions for anaphylaxis. Anaphylaxis is also called anaphylactic shock. It is an acute but potentially life-threatening type 1 hypersensitivity reaction, meaning that type 1 hypersensitivity reaction, anaphylaxis is considered an immediate emergency condition. So, di ba in disaster nursing, sa emergency nursing, there is sa triage, there is immediate, urgent, etc. So, anaphylaxis is under immediate. Immediate siya. So, it is tagged with color red in triage, which requires immediate, accurate diagnosis and appropriate management. So, you know na if ma-face ka with anaphylaxis in an emergency situation, pinaspasay jud siya. It needs immediate na diagnosis and treatment. So, anaphylaxis is marked by the sudden onset of rapidly progressive urticarial and respiratory distress. Urticaria refers to vascular swelling in the skin, accompanied by itching, which will be shown later in a picture. So, syempre, immediate jud basta naa na respiratory distress. Kay mao jud na ang priority pag naay airway obstruction and similar nga mga symptoms na na-compromise na gani ang respiratory system, ang airway, breathing, mao jud na pinaka life-threatening. That's why immediate ang anaphylaxis. So, anaphylaxis is caused by ingestion of or other systemic exposure to sensitizing drugs or other substances. These substances may include serums, vaccines, allergen extracts, enzymes, hormones, and penicillin or other antibiotics. In short, anaphylaxis is caused by ingestion, meaning makakaon or ma-expose kag any drugs or substance na mag-cause og allergic reaction or hypersensitivity reaction. So next slide, diagnosis. There is no single diagnostic test that can identify anaphylaxis. It can be diagnosed by the rapid onset of severe respiratory or cardiovascular symptoms after ingestion or injection of a drug, vaccine, diagnostic agent, food, or after an insect sting. So, pero there are tests. These tests may provide some clues to the patient's risk for anaphylaxis. So, we have skin tests showing hypersensitivity to a specific allergen or elevated serum IgE levels. So, kabalo naman mo nga no skin test, no? Kaya if ma-expose ang patient sa allergen, mag-react man dyan ang skin, magpula-pula, magkatul, mag-rash. So, may balaan mo if allergic ang patient to a certain drug or substance. Also, ang IgE or immunoglobulin E serum levels, kay mas higher ang IgE antibodies sa blood, na makita sa blood pag allergic ang tao sa isa ka substance. Kay normally, ang tao, naadyo siya some IgE antibodies makita sa blood, normally, pero gagmay lang. Pero if allergic ang tao sa isa ka allergen or isa ka substance, makita dyan na siya sa blood with a blood test, kay mudaghan jud ang IgE antibodies na makita sa blood. Pag more than 150 international units per ml ang IgE sa blood, meaning allergic ang patient ana na substance, more than 150. So, in summary, walay diagnostic test para ma-determine ang anaphylaxis. That is why ang best preparation for nurses when it comes to this emergency condition is to know its signs and symptoms. Since wala man siya diagnostic test, dapat kabalo ka sa signs and symptoms. Kaya ang signs and symptoms niya ang makahelp para ma-diagnose ang anaphylaxis. And why wait para ma-diagnose siya other than aning katong signs and symptoms and katong skin test o elevated IgE serum levels, which is dili jud na mauyahang diagnostic test. Maghatag lang siya clue nga at risk ang patient for anaphylaxis on a certain substance. So, ang himuon sa nurse is i-assess jud dayon niya if nagka-reaction ang patient like respiratory or sa skin and other symptoms after magkaon or ma-expose to a substance. What to look for? Mao ni ang signs and symptoms of anaphylaxis. Number 1, airway obstruction. Ang feeling sa patient, there is a lump in the throat. Murag sakit yung tutunla na murag guot, na murag di siya kahinga. There's a lump in the throat. Hoarseness, siyang tingog. Murag may pagaw nga something, lahi ang pagstorya, lahi ang pitch sa pagstorya niya. And stridor, wheezing, dyspnea, lisod siya hinga, and tight yung chest. Ang feeling niya tight yung chest. Next, sa skin niya, there is urticaria or otherwise known as hives. So, kita na siya picture later. And then number 3 is physical distress. Na weakness, sweating, nausea, diarrhea, stomach cramps, headache, dizziness, and babaihang blood pressure or hypotension. So, makita niyo siya diri sa next na picture. Look for these signs. Awan na siyang liog. Mura gaglisod siya og hinga. Basta na lump, ang feeling nila na lump sa throat. Then kaning sa baba, kaning sa likod good, nga na pula-pula nga butoy-butoy. So tawag na hives or urticaria. Mo ni urticaria. And then sa pika, so mo ni siya summary sa mga signs and symptoms. There is headache, loss of consciousness, confusion, swollen eyes, swollen lips or tongue, wheezing, cough or difficulty getting air or breathing, to hives, fast heart rate, and abdominal pain or vomiting. The treatment of anaphylaxis focuses on maintaining a patent airway, ensuring adequate oxygenation, restoring vascular volume, and controlling and counteracting the effects of the chemical mediators released. So, di ba nga, classification sa anaphylaxis is immediate because ma-compromise ang breathing, respiratory system sa patient. So, ang focus jud, ang priority for treatment is the oxygenation and airway sa patient. And to counteract the effects of the chemicals na release sa allergen. So meaning, administer dayon ang medications na gi-prescribe sa doctor para ma-stop ang hypersensitivity reaction nga nag-cause sa symptoms sa body sa patient. We have our nursing interventions. The first nursing intervention is administer epinephrine as ordered. Immediate administration of epinephrine or adrenaline 1 gram in 1,000 ml to reverse bronchoconstriction. So, one of the hypersensitivity reactions of the patient to the allergen is bronchoconstriction. Constriction meaning nag-narrow ang broncho or airways sa patient. That's why need og epinephrine to reverse or to stop the narrowing and to allow the patient to have lessened ang iyahang respiratory distress. So, it is given intramuscularly or subcutaneously if the patient is still conscious. So, IV if the reaction, or intravenous if the reaction is severe, with repeating dosage every 5 to 20 minutes as needed. Next, assess the patient's ABCs. Assessing ABCs or airway, breathing, and circulation to determine if the patient is in cardiac arrest. Then, if ma-determine na nimo nga nag-cardiac arrest siya, then begin CPR and provide appropriate care. Next, administer supplemental oxygen as ordered. Oxygen therapy is done to increase tissue perfusion, reverse hypoxemia, and maintain adequate pulse oximetry levels. So, di ba nga, nagka-bronchoconstriction siya. So, naglisod na og perfuse or lusot ang oxygen sa mga tissues. That's why it will cause hypoxemia or maglisod og hinga ang patient, magkaroon siya respiratory distress. Dili na adequate or di na niya ma-maintain ang normal na oximetry levels. That's why need niya og supplemental oxygen as ordered by the physician. Next, assess the patient's vital signs and respiratory status. So initially, at first, every 5 to 15 minutes, and then less frequently if naga-improve ang condition sa patient. Note the continued evidence of hypotension and i-notify dayon ang physician if nagababa gyapon niyang blood pressure. Then auscultate the lungs for decreased adventitious breath sounds. So, meaning, decrease, meaning, naga-better yung condition. So, dapat, i-assess naman na siya. Next, be alert for decreased wheezing. This may signal an improvement in the patient's airflow. So, same magyapon sa vital signs. Bantayan yun mo yung vital signs if naga-improve ba yung condition. However, Decreased wheezing could also indicate worsening of bronchoconstriction and obstruction. So either naga-better yung condition or naga-worse yung bronchoconstriction and airway obstruction. So to determine what's happening, auscultate the air movement throughout the lung fields. If decreased ang wheezing is a result of bronchoconstriction, meaning nagworsen, meaning ang airflow niya nag-decrease. Upon auscultation nimo ang airflow niya ga-decrease. Pero if delay, meaning ga-better yung condition. That's why nag-decrease yung wheezing. Next is observe for a positive response to oxygen therapy, such as improved breathing, color, pulse oximetry, and ABG values. So same gyapon na i-observe nimo to see if nag-better ang condition sa patient or nag-worsen. Next nursing intervention is to expect the administration of vasopressors. Kaya di ba nga, ang signs sa patient pag naa siya'y anaphylaxis is hypotension or babay ang blood pressure. So, vasopressors is administered to raise the blood pressure para motas ang blood pressure. Kaya baba man to stabilize yung blood pressure. So, mag-expect na ka if ang patient wala siya nag-respond sa IV fluid replacement therapy, wala nag-stabilize iyang blood pressure, wala nagtaas iyang blood pressure even with IV. So, mag-expect na ka nga mag-order ang physician to administer vasopressors to raise the blood pressure. Hindi mo ka maghatag dayon, syempre mag-wait po kag-order sa physician. That's why i-monitor jud nimo yahang blood pressure and i-notify din nimo ang physician nga dok wala gyud po nag normalize or nag-stabilize iyang blood pressure. So mag-expect ka possible mag-administer of vasopressor. Next, expect ET or endotracheal intubation. Kaya ang patient iyang airway secretions possible na magtapok and mag-cause og tungod sa iyang hypersensitivity reaction, grabe iyang airway secretions, magtapok na siya sa iyang trachea or sa airway niya, mag-cause og blockage or obstruction. That's why need og endotracheal intubation to maintain the airway patent and masuction tong mga secretions nga nagtapok sa iyang airway. Next, institute continuous cardiac monitoring to determine any signs or identify and treat arrhythmias as ordered by the physician. Kaya pag makita nimo na may arrhythmia, possible magka cardiac arrest, which is fatal. That's why kuan day nimo, notify din nimo physician pag mabantayan nimo while cardiac monitoring, if mabantayan nimo nga nagkaroon ng arrhythmia, notify the physician kay possible mag-order siya para i-treat ang arrhythmia because this may cause cardiac arrest. Next, assist with insertion of a central venous or pulmonary artery catheter. So, we all know, din siya catheter nga katong para sa ihi. Catheter ni siya nga i-connect sa imuhang veins or arteries, then katong nga catheter i-connect sa sa monitor, electric monitor para ma-monitor ang hemodynamics sa patient, iyang cardiac output, ECG. Yan, dira nimo makita iyang hemodynamics, unsa iyang status or condition. Then dira nimo ma-monitor iyang blood pressure ana. So, if indicated, if mag-order ang doktor nga, mag-insert og catheter. So, mag-assist ka na sa insertion. Then, begin IV with crystalloids such as lactated ringer or normal saline solution and colloids such as albumin and plasma protein fraction as ordered by the physician. So, mag-begin ka og IV therapy to diba? IV replacement therapy to stabilize iyang vital signs, iyang blood pressure. Okay, ibaba ba yung blood pressure? Then, assess the patient closely for signs and symptoms of fluid overload such as crackles, jugular vein distension, and increase in hemodynamic parameters because this may lead to complications, cardiovascular complications, cardiac arrest. So, bantayan mo ang fluid overload. Last slide, next nursing intervention is to evaluate peripheral tissue perfusion. So, di ba nga, sa hypersensitivity reaction sa body, pag na siya allergy, during anaphylaxis, kay maglisod o perfuse ang oxygen sa tissues. Magbaba ang oxygen level sa body, magka-bronchoconstriction. That's why, need mo i-monitor and evaluate nimo skin color, temperature, pulses, and capillary refill para mabantayan nimo ang blood flow if nabay block. So, mabantayan nimo ang blood flow throughout the body and oxygen throughout the body. So, diba mabantayan, evaluate nimo siya and ma-monitor through skin color, temperature, pulses, and capillary refill. So, di ba nga, dapat 3 seconds or less than 3 seconds mag-refill na ang capillary refill na. So, dra nimo ma-monitor if if sobraan og 3 seconds, so, di ba, dugay kayo ang blood flow, balik sa iyang tissue. So, i-notify din sa physician if na any abnormalities pag evaluate nimo sa iyang tissue perfusion, because this could be a sign of complication sa iyang condition. Next, monitor intake and output closely. Check nimo yung urine output every hour. Insert an indwelling urinary catheter as indicated and ordered by the physician to ensure accurate measurement. So, muna ni siya ang lahi nga catheter. Sa urine na ni siya nga catheter to accurately measure the urine output of the patient. Notify the practitioner if the urine output is less than 30 ml per hour. So, importante nga i-measure ang urine output, intake and output, because again, this may be a sign of complication, this may be a sign na mag-cardiac arrest siya, because closely related jud ang cardiovascular system ug ang renal function sa body. So, di ba nga nag-hypotension siya, every time magbaba or magtaas ang blood pressure sa patient or sa tao in general, maapektuhan jud ang renal function, and pag maapektuhan ang renal function, apektuhan ang heart. So, i-notify din ng physician if magbaba iyang urine output. Then, administer additional pharmacotherapy as ordered, including antihistamines such as diphenhydramine, H2 antagonists, inhaled beta-adrenergic agonists such as albuterol, and high-dose corticosteroids. So, mo to siyang gingon ganiha. Mag-administer na kaog mga tambal, medicine, pharmacotherapy to i-block nimo tong mga chemical reaction sa body na nag-cause atong allergen. So, diphenhydramine, common na kailan na kita na for allergy. So, mga antihistamines. So, mag-administer ka as ordered by the physician. Next, monitor the level of consciousness or LOC for changes indicating decreased cerebral perfusion. Di ba nga, isa sa mga symptoms sa patient with anaphylaxis is confusion. So, possible tungod nga sa tissue perfusion niya, lisod na perfuse ang blood flow, oxygen sa mga tissues sa body, from the brain to the heart to the renal function. That's why magbaba yung urine output, and then sa heart, and then sa brain. That's why mag-change iyang consciousness. So, i-monitor niyo yung level of consciousness. Pag magbaba gani, meaning nag-decrease ang cerebral perfusion or tissue perfusion sa brain. Baba ang oxygen sa brain, baba ang blood flow sa brain, nagbaba ang oxygen sa brain. So, maapektuhan iyahang consciousness. So, that's why monitoring mo yung level of consciousness. Next, institute measures to control itching. Kaya di ba nga, medyo na pinaka-first pag nag-allergic reaction ng patient, magkatul-katul, magkaroon og hives or urticaria, magpula-pula, butoy-butoy, magkatul-katul. So, you need to help the patient to control the itching. Kapag magsige siya og katol, maapektuhan niyang skin integrity. So, dapat nato na siya i-control. I-help na to ang patient. Such as cool compress, avoidance of scratching, and using finger pads instead of nails. Or medyas na lang. Tagaan mo siyang medyas. Dili na yama, samad iyang skin. Kung samad iyang skin, mas daghan na yung problema. Pwede ma-infect or especially pag diabetic ang patient, maglisten na ayo iyang samad kung masigi siya katol. So, yeah. Next, lastly, reassure the patient and stay with him or her. Help him or her relax as much as possible. That's all. Thank you.
Next topic will be thoracic emergency trauma. We will discuss all about the definition, the signs and symptoms, diagnostic studies, and important nursing interventions. So the definition of the thoracic trauma. So thoracic trauma are any injuries to the chest area anywhere between the neck and the abdomen. And damage may be to the chest wall, the bones including the ribs and the sternum, skin, fat, and muscles protecting the lungs, or any of the organs inside the chest, for example, the heart or lungs. Major chest trauma may occur alone or in combination with multiple other injuries. And chest trauma is actually classified as either blunt or penetrating trauma. Blunt chest trauma results from sudden compression or positive pressure inflicted to the chest wall, and penetrating trauma occurs when a foreign object penetrates the chest wall. So blunt chest trauma. So this mechanism is caused by increased intrathoracic pressure such as car collision, which is the most common cause of thoracic trauma, and including falls also. Although blunt chest trauma is more common than penetrating trauma, it is often difficult to identify the extent of the damage because the symptoms may be generalized or vague. In addition, blunt trauma to the chest may result in laceration of lung tissue or an artery by a rib, causing blood to collect into the pleural space. This actually happens during hemopneumothorax. The most common cause of blunt chest trauma are motor vehicular crashes, such as trauma from steering wheels or seat belts. It can also happen during falls and bicycle crashes, like trauma from handlebars. The mechanism of blunt chest trauma includes the acceleration, deceleration, shearing, and compression. Acceleration happens when there is a moving object hitting the chest or the patient being thrown into an object. Deceleration happens when there is a sudden decrease in rate of speed or velocity, such as in a motor vehicle crash. Shearing happens when stretching force to the areas of chest, causing tears, ruptures, or dissection of tissue. And lastly, the compression, which is the direct blow to the chest, such as in crash injuries. Next is the penetrating trauma. This is actually a chest trauma in which a weapon such as knife, bullet, or needle can cause laceration to the lung tissue. Penetrating injury is usually results from the abrupt, direct application of mechanical force to the focal area of the chest wall. So a knife or a projectile produces tissue damage by stretching and crushing, and injury is usually confined to the tissue in the path of penetration. So the severity of the internal injury depends on the organ penetrated and on how vital the organ is. The mechanism of injury may be categorized as low, medium, or high velocity. So low velocity injuries includes the use of knives, daggers, pieces of glasses, or sharp metals that can cause stab wounds, and it is usually produce limited injury. Medium velocity injuries includes bullet wound from most type of handguns and air-powered pellet guns, and are characterized by much less primary tissue destructions than a wound caused by high velocity forces. On the other hand, high velocity injuries includes bullet wound caused by rifles and wounds from military weapons. Life-threatening injuries associated with thoracic injuries may include airway obstruction, tension pneumothorax, which is a severe case of pneumothorax compared to the open and closed pneumothorax, since there is a formation of one-way valve into the chest wall. We also have open pneumothorax, which can happen from stab wounds or gunshot wounds, flail chest and pulmonary contusion. We also have massive hemothorax from severe bleeding causing the blood to accumulate into the pleural space. And lastly, we have cardiac tamponade. So thoracic injury may actually cause pneumothorax and pleural effusion. So pneumothorax is a condition where there is accumulation of air into the pleural cavity, and pleural effusion is accumulation of fluid into the pleural spaces. However, this fluid may be transudate, exudate, or even blood. So the sign and symptoms for pneumothorax, we have atelectasis, which is the collapse of a lung, dyspnea, fatigue, cough, chest pain. Breath sounds are also reduced over the atelectic area. This indicates that the lungs is already collapsed. There's also unequal chest expansion and shifting of the mediastinal contents towards the unaffected side. Patient may also exhibit hypoxia, which further develops to sympathetic response, including anxiety, tachycardia, and pallor. Pneumothorax will also interfere with the venous return, leading to hypotension, since pneumothorax will push the mediastinal contents towards the unaffected side, causing to impede the venous circulation. For pleural effusion, specifically hemothorax, we have dyspnea, chest pain, fatigue due to mild or moderate or even severe blood loss, increased respiratory and heart rate, and there will be dullness during percussion and absence of breath sounds over the affected area. There is also a tracheal deviation and hypotension, which indicates a massive effusion that interferes with both respiratory and circulatory function of the patient. A sharp and stabbing wound and chest pain, which aggravates during breathing, possibly radiating to the neck, shoulders, and abdomen. For the diagnostic studies, we have chest x-ray, which helps evaluate the organs or structures within the chest and is the initial study of choice in blunt force chest trauma. We also have thoracic computed tomography, which enhances the anatomic views of the chest and locates abnormalities. And lastly, we have chest ultrasonography, a non-invasive diagnostic exam that produces images used to assess the organs and structures within the chest, such as lungs, mediastinum, and pleural spaces. So next will be the nursing interventions. So patient with traumatic chest injury may exhibit ineffective breathing pattern. So we must monitor the respiratory function of the patient. So we have independent nursing intervention. First, we must identify the etiology or the cause, such as trauma, malignancy, infection, complication of mechanical ventilation. This will help us understand the cause of lung collapse, which is very necessary for proper chest tube placement and choice of other therapeutic measures. We must also evaluate the respiratory function of the patient, noting rapid or shallow respiration, if there are any difficulty breathing, reports of air hunger, and development of cyanosis and changes in vital sign. Respiratory distress and changes in vital sign occur because of physiological stress and pain, or may indicate development of shock due to hypoxia or hemorrhage, which is commonly due to penetrating trauma or blunt trauma. Monitor also for asynchronous respiratory pattern when using mechanical ventilator, noting any changes in airway pressures. So difficulty of breathing with ventilator or increasing airway pressures, such as worsening of condition and development of complication, such as tension pneumothorax. Auscultate also for breath sounds, since breath sounds may be diminished or absent in a lobe, lung segment, or the entire lung. This will help us identify atelectic area. We must also note the chest exertion and position of trachea. Chest exertion is usually unequal until lung re-expand, and trachea may deviate from affected side with tension pneumothorax. This happens during shifting of the mediastinal contents towards the unaffected side. For the ventilation assistance, first we must assist the client with splinting painful area when coughing or during deep breathing. This will help the client support chest and abdominal muscle and makes coughing more effective and less traumatic. Maintain also position of comfort, usually with head of bed elevated, turn to affected side. Encourage the client to sit up as much as possible. So this will promote maximal inspiration and enhances lung expansion and ventilation in unaffected side. Maintain also a calm attitude environment, assisting client to take control by using slower, deeper respirations. This will help the client to deal with the physiologic effect of hypoxia, which may be manifested as anxiety or fear. Next will be the chest tube care. So we must ascertain type of client's chest drainage system that will be used later. So this care plan actually concerns the hospitalized client whose treatment plans include use of a traditional chest drainage system. We must also seal the drainage tubing connection sites securely with lengthwise tape or bands and pad bands with gauze or tape according to established policy once chest tube is inserted. This will prevent disconnection and air leaks at the connector sites. We must also anchor the thoracic catheter to chest wall and provide extra length of tubing before turning or moving the client. This will prevent catheter dislodgement or tubing disconnection and reduces pain and discomfort associated with pulling or jarring of the tubing. Monitor also for thoracic insertion site, noting condition of skin and presence of characteristics of drainage from around the catheter. This will provide information and early detection of skin or tissue erosion or even infection. We must also determine if dry seal chest drain or water seal system will be used, since some chest drain use a mechanical one-way valve in place of a conventional water seal. The one-way valve allows air to escape from the chest and prevents air from entering the chest again. If water seal system and suction is used, we must check the suction control chamber for correct amount of suction. Usually, the safety valve is submerged to water about 20 cm. This will maintain the prescribed intrapleural negativity, which promote optimum lung expansion and fluid drainage. We must also check the fluid in the water seal chamber, usually maintained at the prescribed level of 2 cm. This is very important since the water in a seal chamber serves as a barrier that prevents atmospheric air from entering the pleural space. Observe also for bubbling in the water seal chamber, since bubbling during expiration reflects a venting of pneumothorax. However, we must note that bubbling decreases as the lung expand or may occur along during expiration, or coughing as the pleural space diminished. An absence of bubbling may indicate complete lung expansion, which is normal, or presence of complications such as obstruction in the tube or even air leak. Observe also for abnormal and continuous water seal chamber bubbling, since this may indicate a persistent air leak. Determine also the location of air leak, and if bubbling stops when the catheter is clamped at the insertion site, the leak is patient-centered, and if not, then it can be a system-centered. Place petroleum gauze or other appropriate materials around the insertion site as indicated. This will correct insertion site air leak. And we must also note the character and amount of chest tube drainage, whether tube is warm and full of blood, and whether bloody fluid level in water seal bottle is rising. This is very useful in evaluating resolution of pneumothorax or development of hemorrhage requiring prompt interventions. If the thoracic catheter is disconnected or dislodged, we must observe for signs of respiratory distress, and if possible, reconnect the thoracic catheter to tubing and suction using clean technique. If the catheter is dislodged from the chest wall, we must cover insertion site immediately with petrolatum dressing and apply firm pressure, and notify the physician at once. After the thoracic catheter is removed, we must cover the insertion site with sterile occlusive dressing, and observe for signs or symptoms that may indicate recurrence of pneumothorax, such as shortness of breath and reports of pain. We must also inspect the insertion site and noting character of drainage. Early detection of development of complications such as recurrence of pneumothorax or presence of infection is essential. For collaborative nursing intervention, we must monitor and graph serial ABGs and pulse oximetry, review the vital capacity and tidal volume measurement. This will help us assess the status of gas exchange and ventilation and need for continuation or alteration in therapy. Administer also supplemental oxygen via cannula, mask, or mechanical ventilation as indicated. This will help the client aids in reducing the work of breathing and promote relief of respiratory distress and cyanosis associated with hypoxemia. Administer also analgesics and sedative as indicated. This will manage pleuritic pain and reduce anxiety and tachycardia associated with impaired respiratory function.
So next is the cardiac arrest. Cardiac arrest is the abrupt loss of heart function in a person who may or may not have been diagnosed with heart disease. Cardiac arrest occurs when the heart suddenly and unexpectedly stops pumping. If this happens, blood stops flowing to the brain and other vital organs. Cardiac arrests are caused by certain types of arrhythmias that prevent the heart from pumping blood. So a common arrhythmia that is associated with cardiac arrest is ventricular fibrillation. During ventricular fibrillation, the lower heart chambers contract in a very rapid and uncoordinated manner. Because of that, the heart doesn't pump blood to the rest of the body. Yes, Kai, it doesn't pump enough blood na sa whole body kay tungod. Sige na lang siya pump and then wala na time mag-refill ang heart. So for the signs and symptoms, signs of sudden cardiac arrest are immediate. This includes sudden collapse, no pulse, no breathing, and of course, loss of consciousness. Sometimes other signs and symptoms occur before sudden cardiac arrest. This might include
chest discomfort, shortness of breath, weakness, fast beating, fluttering, or pounding heart, or for short, palpitation. So, for the medical management, when the heart stops, the lack of oxygen-rich blood can cause death or permanent brain damage within minutes. Time is critical when you're helping an unconscious person who isn't breathing. If you see someone collapse and may be suffering from cardiac arrest, first thing to do is to ensure scene safety. Of course, it is important to make sure the scene is safe and that there is no danger threatening you or the person you are trying to help. Even after you begin providing first aid, you must remain aware of your surroundings and alert to anything on the scene that might change and put you in danger. So second is check for response. So if there is no response, assess pulse and breathing. So if there is no pulse and breathing, so call for help. If you are with someone, tell her to call 911 and get back to you immediately. And begin high quality CPR. And then next is use an automated external defibrillation as soon as it arrives. Turn it on and follow the prompts. Continue CPR until the person starts to breathe or move until someone with more advanced training such as EMS team member takes over.
Good day, I am Ice Cristila Badan and I am going to discuss the external hemorrhage. Bleeding, also called hemorrhage, is the name used to describe blood loss. Blood loss can occur in almost any area of the body. External bleeding happens when blood exits through a break in the skin. Blood loss from bleeding tissue can also be apparent when blood exits through a natural opening in the body such as the mouth, vagina, rectum, or nose. Traumatic bleeding is the term used when the bleeding is visible or occurs externally. An injury can cause traumatic bleeding. Traumatic injuries vary in their severity. Common types of traumatic bleeding include abrasions or scrapes that do not penetrate too far below the skin, hematoma or bruises, lacerations or cuts, puncture wounds from items like needles, nails, or knives, crushing injuries, or gunshot wounds. When is bleeding a sign of emergency? So if a bleeding is severe, then seek medical help immediately. So seek medical help if the person has gone into shock or has a fever, the bleeding cannot be controlled using pressure, the wound requires a tourniquet, the bleeding was caused by a serious injury, the wound may need stitches to stop bleeding, foreign objects are stuck inside the wound appears to be infected such as swelling or leaking a whitish yellow to brown pus, or has redness. The injury occurred due to a bite of an animal or human. In most cases, emergency services will tell you to continue to put pressure on the wound and keep reassuring the person who's bleeding. You may also be told to lay the person down to reduce the risk of fainting. First aid for traumatic bleeding. So first, of course, seek emergency help if the person is having any of the emergency signs that I have mentioned. The person who is bleeding should try to remain calm to keep their heart rate or blood pressure controlled. Either heart rate or blood pressure being too high will increase the speed of bleeding. Remove loose debris and foreign particles from the wound. Leave large items such as knives, arrows, or weapons where they are. Removing these objects can cause further harm and will likely increase the bleeding. In this case, use bandages and pads to keep the object in place and absorb the bleeding. Use the following to put pressure onto the wound: a clean cloth, bandages, clothing, your hands after applying protective gloves. Maintain medium pressure until bleeding has slowed and stops. So here are the things that you should not do after applying the first aid. So first, do not remove the cloth when bleeding stops. Use an adhesive tape or clothing to wrap around the dressing and hold it in place. Then place a cold pack over the wound. Do not look at the wound to see if bleeding has stopped. This can disturb the wound and cause to begin bleeding again. Do not remove the cloth from the wound even if the blood seeps through the material. Add more material on top and continue the pressure.
Do not move anyone with an injury to the head, neck, back, or leg. Do not apply pressure to an eye injury. For the use of tourniquets, it should only be used as last resort. An experienced person should apply the tourniquet. To apply the tourniquet, follow these steps. First, identify where to place the tourniquet. Apply it to a limb between the heart and the bleeding. Next, make the tourniquet using bandages if possible. Wrap them around the limb and tie a half knot. Ensure there is enough room to tie another knot with the loose ends. Third, place a stick or rod between the two knots. Fourth, twist the stick to lighten the bandage. Fifth, secure the tourniquet in place with tape or cloth. Sixth, check the tourniquet at least every 10 minutes. If the bleeding slows enough to be controlled with pressure, release the tourniquet and apply direct pressure.
Good day, I am Hamza Aisa. So here are the continuation of our report, head injury. Head injury, also known as brain injury, is the disruption of normal brain function due to trauma, blunt or penetrating injury. Neurologic deficit result from the sharing of the white matter, ischemia, and mass effect from the hemorrhage and cerebral edema of the surrounding brain tissue. Head injury is any trauma to the skull on the brain. If it can be either the close or open. Close injury, head injury means you receive the hard blow to the head from the striking an object or accident. Open or penetrating head injury means you were hit an object that broke the skull and entered the brain. This more likely happened during car accident or gunshot. Type of brain injury: first, concussion; second, contusion; third, cerebral hematoma; fourth, skull fracture. Concussion is a result of diffuse and microscopic injury to the brain. The force of the blow caused temporary neurologic impairment but no serious damage to cerebral tissue. It is an injury to the head that very cause instant loss of awareness or alertness after the traumatic injury. The assessment finding for the patient for the client is the client will be having a temporary disorientation, blurred and double vision, emotional irritability, and dizziness. Second is contusion. It is more serious than a concussion and leads to gross structural injury to the brain. Contusion is a bruise to the brain itself, causes bleeding and swelling inside the brain. It may occur with a skull fracture or other blood clots such as a subdural or epidural hematoma, meaning there's a bleeding occur inside your brain. The sign and symptom may depending on the severity of the blow and the degree of head velocity. So if the patient is unconscious, the patient will usually respond to strong stimuli such as pressure applied to the base of the nail, and if the client is awakening, the client will be having temporary amnesia for recent event. Cerebral hematoma is a bleeding within the skull, accumulation of blood form an expanding lesion. Most hematoma result from the head trauma, so it occur bleeding inside the brain rather. Skull fracture is a break in the continuity of the cranium. The most common type of the simple depressed or comminuted fracture. The sign and symptoms simply skull fracture produce few in any symptom and it can heal without any complication. The client may complain localized headache. Sign and symptom of head injury is the sign of increased intracranial pressure is altered level of consciousness, diluted pupil response, vomiting, wideness, pulse pressure, hyperthermia, headache, vertigo, trouble walking or speaking, drainage, bloody or clear fluid from ear or nose, vomiting, seizures, weakness or numbness of arm and legs. Diagnostic tests. First is CT scan. Uh, it is used. Uh, it is used to quickly visualize the fracture and uncover evidence of the bleeding in the brain. MRI is used powerful radio wave and magnet to create details view of to the brain. This test may be used after the person from the condition stabilized or if the symptoms don't improve from after the injury. Next is nerve conduction velocity. Is This test measure how fast an electrical impulse move through our body, through our nerve, and it can also identify if our nerve is good or there is a damage. Next is electronestography. It is used to evaluate the people vertigo and certain other disorders that affect the hearing and vision of the client. And lastly, the ultrasound imaging or sonography use high frequency sound waves to view inside our body. It can also show movement of the body, internal organ, as well as the blood forming through the blood vessel. Next is the pharmacological intervention. The management of intracranial pressure is osmotic diuretic, corticosteroid, mechanical hyperventilation, barbiturates to induce the coma, and second, to antibiotic to prevent the infection in open skull fracture or in penetrating wound. The surgical management is craniotomy with open surgery. It is removal of the part of the bone from the skull to expose the brain. It is a minimal invasive surgery. Next is endoscopic ventriculostomy. It is an alternative surgical procedure that create a bypass for the cerebrospinal fluid in the head to eliminate the need for shunt. Next is decompressive craniotomy, used to test uh, to elevate the intracranial pressure that is a response to conventional treatment modality, and cranio- cranioplasty, a surgical procedure that repair of the bone deficient in the skull resulting from the previous operation and injury. Next is the nursing intervention. First, maintain the intracranial pressure monitoring as indicate and report abnormalities. Second, monitor for sign of meningitis or ventriculitis as a result of skull fracture and respiratory, urinary tract, or systematic infection caused by immobility. Third is monitor result of the serum and urine electrolytes and osmolality study to maintain the level of dehydration of the client in order to reduce the cerebral edema. Fourth is monitor high hemodynamic measurement. Fifth is monitor respiratory rate, depth, and pattern of respiration. Report any abnormalities patterns such as skin stalk respiration or period of apnea, and constant vigilance of agitate patient confined to bed and avoid restraint if possible. So that's all for my topic. Thank you.
Good day everyone. Today we will be discussing about stroke, or also known as the cerebrovascular accident. Now, stroke occurs when the blood supply to the brain is reduced or blocked, and this prevents the brain tissue from getting the oxygen and nutrients that it needs. A stroke is a medical emergency and prompt treatment is crucial. Early action can reduce brain damage and other complications. Effective treatments can also help prevent disability from stroke. The first type of stroke is the ischemic stroke. This is the most common type of stroke. It happens when the brain's blood vessels become narrowed or blocked, causing ischemia. Blocked or narrowed blood vessels are caused by fatty deposits that build up in blood vessels or by blood clots or other debris that travel through the bloodstream and lodge in the blood vessels in the brain. On the contrary, hemorrhagic stroke happens when a blood vessel in the brain leaks or ruptures. Brain hemorrhages can result from many conditions that affect the blood vessels. Hemorrhagic stroke is of two types. The first one is the intracerebral hemorrhage, which occurs within the brain tissue, and subarachnoid hemorrhage, where the leaked blood occupies the subarachnoid space. The bleed may be small or large. A transient ischemic attack or TIA, sometimes known as a mini stroke, is a temporary period of symptoms similar to a stroke. A TIA doesn't cause permanent damage. They're caused by a temporary decrease in blood supply to the part of the brain, which may last as little as 5 minutes. Like an ischemic stroke, a TIA occurs when a clot or debris reduces or blocks the blood flow to the part of the nervous system. A person should seek emergency care even if he or she thinks they had a TIA because the symptoms got better. It is not possible to tell if the person is having a stroke or TIA based only on the symptoms. Even if a person had a TIA, it means he or she may have a partially blocked or narrowed artery leading to the brain, and having a TIA increases the risk of having a full-blown stroke later. So it is a must that a person or the patient should have a checkup right after the event. Stroke symptoms. As different parts of brain control different parts of the body, symptoms will depend on the part of brain affected and the extent of damage. The main symptoms are paralysis or numbness or inability to move parts of the face, arm, or leg, particularly on one side of the body. Next, confusion, including trouble with speaking, headache with vomiting, trouble seeing in one or both eyes, metallic taste in mouth, difficulty in swallowing, trouble in walking or impaired coordination, dystonia, alexia, and agnosia. So, what causes these strokes? For the ischemic stroke, the obstruction to blood flow is usually due to a thrombus or an embolism within the blood vessel. For the hemorrhagic stroke, this stroke follows bleeding in the brain, and for the transient ischemic attack or the mini stroke, is caused by the same conditions that cause an ischemic stroke, like thrombosis, embolism, or other conditions like arterial dissection, arteries, or hypercoagulable states. TIA does not leave lasting symptoms because blockage is only temporary. Risk factors include being overweight, having a sedentary lifestyle, binge drinking, diabetes, smoking, having a high blood pressure, high cholesterol, family history of stroke, cardiovascular diseases, age, and people above age 55 are at higher risk, and gender, because men are at high risk of stroke than women. To determine the most appropriate treatment for stroke, an emergency team needs to evaluate the type of stroke a person is having and the areas of the brain that is affected. To diagnose, first we have physical examination, where patient's symptoms, medical history, blood pressure, and blood vessels at the back of the eyes are checked. Second, blood test. This is to find out the time taken for the clotting of blood. Third, CT scan, where the images of the brain can show a hemorrhage, tumor, stroke, or other medical conditions. Fourth, ultrasound. This is to check the blood flow in the carotid arteries and to check for plaque if there's any. Fifth, MRI. MRI of brain tissue to diagnose ischemic stroke or brain hemorrhage. Sixth, cerebral angiogram, where dye is injected to get a detailed view of the brain and neck blood vessels that is visible under X-ray. And last, echocardiogram to check for any sources for clots that could have traveled to the brain and lead to a stroke.
Emergency treatment for stroke depends on whether a person is having an ischemic or hemorrhagic stroke. To treat an ischemic stroke, the doctors must quickly restore blood flow to the brain. This may be done with emergency IV medications, where therapy with drugs that can break up a clot has to be given within 4 to 5 hours from when a symptoms first started if given intravenously. An IV injection of recombinant tissue plasminogen activator or TPA, also called alteplase activase, is the gold standard treatment for ischemic stroke. This drug restores blood flow by dissolving the blood clot causing the stroke. Next, emergency endovascular procedures. Doctors treat ischemic strokes directly inside the blocked blood vessel. Third, medications delivered directly to the brain, where doctors insert a long, thin tube or a catheter through an artery in the groin and thread it into the brain to deliver TPA directly where the stroke is happening. Next, removing the clot with a stent retriever, where doctors can use a device attached to a catheter directly remove the clot from the blocked vessel in the brain. Emergency treatment of hemorrhagic stroke focuses on controlling the bleeding and reducing pressure in the brain caused by the excess fluid. Treatment options include: first, emergency measures. If patient takes blood-thinning medications to prevent blood clots, he or she may be given drugs or transfusions of blood products to counteract the blood thinner's effects. Patient may also be given drugs to lower the pressure in the brain or the intracranial pressure, lower the blood pressure, prevent spasms of the blood vessels, and prevent seizures. Next, surgery. If the area of the bleeding is large, the doctor may perform surgery to remove the blood and relieve pressure on the brain. Surgery may also be used to repair blood vessel problems associated with hemorrhagic strokes. Third, surgical clipping. A surgeon places a tiny clamp at the base of the aneurysm to stop blood flow to it. This clamp can keep the aneurysm from bursting, or it can keep the aneurysm that has recently hemorrhaged from bleeding again. Fourth, coiling or endovascular embolization. Using a catheter inserted into an artery into the groin and guided to the brain, the surgeon will place tiny detachable coils into the aneurysm to fill it. This blocks blood flow into the aneurysm and causes blood to clot. Last, stereotactic radiosurgery. Using multiple beams of highly focused radiation, stereotactic radiosurgery is an advanced, minimally invasive treatment used to repair blood vessel malformations. Nursing assessment and interventions. First, we have to assess the airway patency and respiratory pattern. Neurologic deficits of a stroke may include loss of gag reflex or cough reflex. Thus, airway patency and breathing pattern must be a part of the initial assessment. Next, frequently assess and monitor neurological status. Third, monitor changes in BP. and compare BP readings in both arms. Hypertension is a significant risk factor for stroke. Fluctuation in blood pressure may occur because of cerebral injury in the vasomotor area of the brain. Fourth, monitor heart rate and rhythm and assess for murmurs. Changes in rate, especially bradycardia, can occur because of brain damage. Next, evaluate pupils, noting its size, shape, equality, and light reactivity. Pupil reactions are regulated by the oculomotor and help determine whether the brainstem is intact. Next, assess higher functions including speech if the patient is alert. Changes in cognition and speech content indicate location and degree of cerebral involvement and may indicate deterioration or increased ICP or the intracranial pressure. For our interventions, position the patient's head slightly elevated and in a neutral position. This reduces arterial pressure by promoting venous drainage and may improve cerebral perfusion. During an acute phase of stroke, maintain the head of the bed less than 30 degrees. Next, maintain bed rest. Provide a quiet and relaxing environment, restrict visitors and activities. Cluster nursing interventions and provide rest periods between care activities. Limit also the duration of the procedures. Continuous stimulation or activity can increase intracranial pressure. Absolute rest and quiet may be needed to prevent rebleeding. Next, instruct patient to prevent straining at stool, holding breath, and physical exertion. Valsalva maneuver increases intracranial pressure and potentiates the risk of rebleeding. Next, administer supplemental oxygen as indicated. This reduces hypoxemia. Hypoxemia can cause cerebral vasodilation and increase pressure or edema formation. Next, administer medications as indicated. Next, monitor laboratory studies as indicated, which includes prothrombin time, activated partial thromboplastin time, and dilantin level. This provides information about drug effectiveness and therapeutic level. Prepare for surgery as appropriate, such as endarterectomy, microvascular bypass, and cerebral angioplasty. It may be necessary to resolve the situation, reduce neurological symptoms of recurrent stroke. So that is all, and thank you very much for listening.